Sorry. Yeah. So coming to stage uh, 3. So basically, so stage 4, which may or may not be. Stage 3 has spread to tissue near the breast and skin and the chest wall, including the ribs and the chest muscle, but not nearby the left lymph nodes. The tumor, any size, has spread to tissue near the breast or to the axillary nodes or to internal mammary lymph nodes. So that is stage 3. Stage 4 is basically just the tumor has spread to tissues near the breast. I'm just started. Yeah. Yeah. So stage 4, the tumor which may or may not have spread to tissue near the breast and spread to local lymph nodes and to other organs in the body. Most often the bones, lungs, and the liver or the brain is involved. So there is a metastasis from breast to these organs. So that is stage 4. So the stage 4 means the disease is aggressive. So it requires chemotherapy, surgery, and radiation as a multidisciplinary treatment. In stage 1, mostly surgery and the hormonal treatment is managed. So when a patient, so coming to the treatment options, surgery, lumpectomy, mastectomy, I'll just share you the pictures of lumpectomy and mastectomy also, what they are exactly. Radiotherapy, chemotherapy, hormonal, and immunotherapy. So breast cancer is a treatment of multidisciplinary treatment of radiation oncologist, medical oncologist, and surgical oncologist. So depending upon the staging and the grading, the treatment is this. So this is lumpectomy exactly. So a small lump is removed surrounding the tissue as per the uh, tumor size. That is lumpectomy. So it is localized. So the incision is made. So removal of tumor within the margin of normal tissue and possibly some underarm lymph nodes to be tested for cancer. So why lymph nodes are removed? Basically to understand whether the breast tissue has traveled from the lymphatic drainage from the ducts to the lymph nodes and whether it is spreading to other parts of the body. So that hence the lymph nodes are also tested. So smaller breast tumors are often managed with lumpectomy, in which case tumor is removed, but the rest of the breast is left intact. So depending upon the size, the surgery is decided. Surgery, modified radical mastectomy, removal of complete breast, underlying the pictorial space, underlying the axillary lymph nodes. So remove the bulk of the tumor surgically, followed by radiation treatment. So RT is for radiation therapy. So once the tumor is removed with the margins means the marking which surgeons makes around that margin, and the radiation therapy is given to prevent micrometastasis. That is further any post-surgery growth of cancer can be prevented. That's why the radiation is given over the region after operation. So adjuvant systemic therapies given in the breast cancer, that is ER. So normally in a breast cancer, when the patient comes, doctor advises for some tests like ERPR test, HER2 test. So after seeing all these reports, they decide the treatment line. So in case patients are ERPR positive, that is estrogen progesterone positive, then the hormonal treatment is decided. And considering the tumor size, the protocols are there. And if it is estrogen negative, then combination chemotherapy is preferred. So CMF is a regime, cyclophosphamide, methotrexate, and 5-FU every 28 days for 6 cycle is given. Then another protocol, AC protocol, that is A stands for adriamycin, so which has drug doxorubicin plus cyclophosphamide every 3 weeks for 4 cycles. Another regime is AC followed for, this is for estrogen negative patients. AC followed by paclitaxel, which is a taxane for 4 cycles of AC followed by 4 cycles of paclitaxel. So the combinations yesterday we discussed as per the cell cycle, different drugs act. So there is a combination used in the chemotherapy. So what are the side effects? Pain after the operation, tightness or discomfort over the chest, lymphedema, that is water retention, built up at the lymphatic fluid that may cause swelling often in the arm on the same side as affected by the breast. That's why the surgeons ask to visit post operation after removal of nodes or breast to examine whether there is any lymphedema taking place. So lymphedema may produce stiffness in the arm or shoulder, so which patients normally complain. So the surgeons, they examine and take the precaution. So mastectomy is complete removal of breast. You can see the dotted line. These are the margins which are drawn by the surgical oncologist. Depending upon the tumor and the chances of tumor spreading across the breast, the decision is taken by the surgeon in consensus with the patients. So segmental mastectomy. So overall the cancer along with the segment, larger area, normal breast tissue is removed in a segment. This is as per the tumor size. So modified radical mastectomy, removal of complete breast, underlying pictorial fasciae, underlying axillary nodes, and post-operative radiation treatment to prevent local recurrence. That is micrometastasis prevention. So modified radical mastectomy, this is a pictorial depiction. You can see removal of breast associated, and along with the breast, the lymph nodes are removed. So you can see the margin is drawn such a way so that the breast along with the lymph nodes are removed. Because as you saw in the anatomy, there is a duct and there is a drainage to lymphatic system connecting the node. So whenever there is a breast cancer, it is removed along with the nodes so that the further spread of the breast tissue to other organs through the lymphatic system is prevented. So radiation treatment is given. So treatment recommendation for early stage breast cancer, it is shown. So node positive patients, depending upon the menopausal status, that is premenopausal and postmenopausal, and as per the ER status, the treatment is decided. So already so this is a flow chart showing in node negative patients. When tumor size is less than 1 centimeter, no treatment is therapy is given. But still they analyze the ERPR status and decide the treatment of hormonal. Tumor size more than 3 centimeter, again the ERPR status is analyzed, and as per that, whether chemotherapy or hormonal treatment is to be given is decided. If tumor size is more than 3 centimeter, then chemotherapy is the protocol. So treatment goals basically is to give better quality of life. See, breast is an external organ, but women are concerned about their quality of life. So prolongation of uh, survival, that is the objective of treatment, and systemic chemotherapy and hormonal therapy. Inhibits cancer cell growth and proliferation in metastasis. So these are the goals of treatments. So surgeons decide, oncologists decide the treatment depending upon these goals. Adjuvant systemic therapy, estrogen positive, tamoxifen is given. The tamoxifen dosage is 20 milligram per day for 5 years, which is advised. So this we will discuss in our other presentation of hormonal treatment also in detail. All patients with positive lymph nodes more than 1 centimeter and positive ER, tamoxifen is preferred. So this is the cell cycle, just to recollect about which you already covered. So we have in cell cycle So idea behind showing is that different drugs act at different phases of cell cycle. Hence, the protocol or the regime involves a combination of drugs in breast cancer treatment. So adjuvant systematic therapy, estrogen negative regime patient type, AC protocol is preferred. So which involves doxorubicin 60 milligram per meter square on day 1, followed by cyclophosphamide 600 milligram on day 1. And these cycles are repeated every 21 days for total 4 cycles. So this is a 4 AC regime which is called. AC followed by T. It is a sequential treatment in which doxorubicin 60 milligram is given on day 1 and cyclophosphamide 600 milligram per meter square is given day 1. And these cycles are repeated for 21 days for total of 4 cycles. Followed by, as it is a sequential treatment, so followed by taxane, that is paclitaxel, 175 milligram per meter square IV. And these repeated cycles for 21 days for total 4 cycles. So this is called 4AC, 4P or 4T regime. That. So adjuvant systematic therapy in estrogen negative regimen. Another regimen is CMF. C stands for cyclophosphamide, which is given 600 milligram IV on day 1. Methotrexate is given 40 milligram IV on day 1. And 5-FU, that is 5-fluorouracil, 600 milligram per meter square IV on day 1. Another regime is CAF, that is C stands for cyclophosphamide, 100 milligram meter square on day 1 to day till day 14. Then doxorubicin in this protocol is given 60 milligram per meter square IV on day 1 to day 8. 5-fluorouracil 600 milligram per meter square IV on day 1. Repeat these cycles every 28 days for total of 6 cycles. Okay. Another regime is FEC, 5-fluorouracil, epirubicin and cyclophosphamide. So neoadjuvant chemotherapy. So what is basically neoadjuvant? Treatment given prior to the primary treatment. So that is here surgery is the primary treatment. So why it is given basically to increase the number of for downstaging, which is downstaging means to debulk, who can undergo BCT instead of mastectomy. BCT means removal of debulking the tissue rather than removing the entire breast. The chemotherapy is given to reduce the size of the tumor and and it becomes more operable also, and further chemotherapy is planned. Which basically the objective behind giving neoadjuvant is to increase the survival. So metastatic disease spread to distant sites like bone, soft tissue, liver, CNS, etc. So as we discussed, the breast is connected the lymphatic system. So these breast tumor cells travel from the lymphatic system to different organs like soft tissue, liver, and brain. So, so these are another regimes like single agent regimes, aromatase inhibitors, which is letrozole and anastrozole, which comes in this category. Then docetaxel, capecitabine, then immunotherapy like trastuzumab, lapatinib. So these are other molecules which are used in the breast cancer treatment. So this already we discussed adjuvant systemic therapy. This also we have discussed already. So locally advanced diseases, that is operable stage 3A, inoperable stage 3A. So when the tumor in the breast cancer is spreading or invading into the chest wall or the skin, so it becomes inoperable. So they are called locally advanced. So the tumor is advancing from the breast to the invading to the periphery organs or to the other organs. So treatment for this is basically to start with surgery debulking, pre-operative, that is before the operation, doxorubicin-based regimen is given to reduce the tumor size, and induction therapy with doxorubicin-based regimen, and then they are continued with the hormonal treatment like tamoxifen, depending upon the ERPR status and menopausal status, the hormonal treatment is decided. Metastasis, already we shared this thing. So these are some other protocols which are used in preoperative adjuvant treatment. So paclitaxel based regimens in HER2 positive patients, paclitaxel with trastuzumab is preferred. So there are various protocols in case of HER2 positive patients. So like TCH protocol, then there is a sequential protocol or TAC followed by TCH H regime. So H here stands for Herceptin, that is trastuzumab. Okay, and T stands for taxane. So these are preoperative adjuvant therapy and the regimens which are used for HER2 negative patients. So depending upon the patient type and the diagnostic tests which are done, hormonal treatment, HER2 treatment, the various protocols you can see. There is a AC protocol, EC protocol, TAC regime, CMF regime, AC regime. So doctors decide depending upon the staging, grading, and the diagnostic tests, even newer now, molecular testing, the protocols are decided. So these are preoperative adjuvant therapy regimes, systemic therapy in case of ERPR positive. So these are various protocols. So there is a lot of protocol. These are the NCCN guidelines. So where in HER2 positive patients, trastuzumab is recommended along with the taxanes. Hello, you are able to see the slides?
Yes.
So there are so many protocols depending upon the patient is early stage breast cancer, whether whether patient is metastatic breast cancer, depending upon the tumor size and the ERPR and HER2 tests, various protocols, and there is a okay. So we'll come to see some docetaxel based protocols here, uh, which is monotherapy given. Docetaxel is given along with capecitabine. So here the dosage you can see docetaxel whenever it is in combination, generally it is 75 milligram per meter square dosage given. And when it is a monotherapy, in case of sequential treatment, it is 100 milligram per meter square. So dosi and capecitabine, you can see 1,250 milligram capecitabine dosage is given from 1 to day 14, and these cycles are repeated for 21 days. Similarly, there are other protocols, docetaxel with doxorubicin, which is given 50 milligram per meter square and repeated for 21 days. So in case of HER2 positive patients, docetaxel with trastuzumab is given. Yeah, Fauzia, you are admitted. Docetaxel with trastuzumab is given, uh, where trastuzumab is given 2 to 4 milligram per kg IV. Loading dose is 2 milligram and the maintenance dose is 4 milligram per kg IV. Okay. From on day and repeated for 4 weeks. Again, docetaxel with carboplatin protocol is given 75 milligram per IV day 1, and carboplatin dosage, as you know, as per the area under the curve, day 1 and repeated cycles for 21 days. So post-treatment of whether it is surgery, chemotherapy, what are the routine checkups which is done? Continue cell breast examination even if after the breast cancer is detected to look for cancer reoccurrence. The treatment is done, but still the women have to examine their breast and do routine annually or 6 monthly mammography checkup whether there is a reoccurrence happening or not. even after the treatment. Seek exercise prescription to follow after, since the surgeons remove the lymph nodes along with the breast. So there is a stiffness in the arm of the woman's. So that time there are some hand exercise or the physiotherapy is advised by the oncologist accordingly. So consultation with dietitian to improve diet, increase tissue healing and immune response and cancer fighting abilities. So overall counseling is done to motivate and to have better quality of life and their professional life. So those things are ensured by the oncologists and the dietitians. So survival rate for males and females after treatment. So depending upon the staging, already we saw, as per the staging, if it is a stage 1 patient, the survival chances are 100%. If it is a stage 1, then it is 96%. So there is a these are some predictions made depending upon the stage. Stage 4, the chances of survival is 24%. However, with evolving treatments in breast cancer with genomic, the survival of the cancer patients is getting extended because we are entering into more definitive treatment along with chemotherapy. So the future, it would be a combination of immunotherapy, targeted therapy, and chemotherapy. So survival is going to extend day by day with evolving newer medicine coming. Okay. So any, as already I said, anything else you want to ask? Any questions on breast cancer treatment and protocols? Hello, Fozia, Ismail, Memosi. Can anybody respond?
Yes, it was clear.
Yeah, any doubts, any questions you want to ask?
No.
So shall I proceed with other brand? What is the
Yeah.
timing at in Ethiopia now?
Uh, 11 a.m.
11 a.m. So shall I take up the next product now?
Yeah, you can proceed.
So any doubt, please ask me, stop me, or you can clarify, or you can chat and ask also if you are hesitant to speak. So we will take up now Mamofen, Mamazol, and Womazol, which are hormonal treatment in breast cancer, basically. So already, as I told, when the patients comes to the doctor, they evaluate different tests in breast cancer, ERPR test, HER2 test, and in HER2 test, they decide whether the patient is premenopausal, postmenopausal, and depending upon that, they decide which molecule to prefer. Okay. So estrogen function, you can see ER nuclear receptors. So ERPR is basically the female hormones. So any hyperactivation in ERPR leads to abnormal growth of breast cancer. So what is the function of estrogen? Has a very vital function in digestive system, reproductive system, nervous system, and growth of tissues. So hormone-dependent breast cancer contains protein molecules called estrogen receptors, which are there on the breast cancer cells. When no estrogen is present, the estrogen receptor remains inactive. When estrogen receptors are exposed to estrogen, they trigger a chain of events that results in tumor growth and multiplication. Okay, so every cell has various biochemical changes or chemical pathways undergoing. So if it is triggered, then there is an cell growth and multiplication. So estrogen is the main hormone in the development of growth of breast cancer. Almost 75% of the breast cancer ER positive. Therefore, estrogen deprivation is the main aim in treating breast cancer. So, if ER is the main root cause in hormonal, so we have to address that. We have to block the overproduction of estrogen. So, the first choice of treatment till date, the gold standard was tamoxifen. So, tamoxifen had been used in ER positive patients. So what is tamoxifen? It is an anti-estrogen activity. It basically inhibits estrogen. So this is a, you can see the pink color, it is a breast tumor. So these are ER cells, and you can see the action of both uh, aromatase inhibitors like anastrozole or letrozole and tamoxifen action. So estrogen production in premenopausal and postmenopausal women. So this is the premenopausal side you can see and postmenopausal. So as a result, you require different treatment or different hormonal treatment for different types of women. Whether if she's a premenopausal, tamoxifen is recommended as per the guideline. If it is a postmenopausal woman, then generally letrozole or anastrozole is preferred. So letrozole and anastrozole is also preferred for patients who do not respond to tamoxifen or after 5 years treatment if the disease is progressing or the patient is not responding to tamoxifen, then also letrozole and anastrozole is preferred. Effect of estrogen deprivation on multiplication of breast cancer. So with estrogen and without estrogen. For premenopausal and postmenopausal metastatic breast cancer, other indication in breast cancer is adjuvant treatment of breast cancer indicated for the treatment of node positive breast cancer in postmenopausal women. Ductal carcinoma in situ in women with following breast cancer surgery, it is indicated to reduce the risk of invasive breast cancer. Reduction in the breast cancer incidence is high risk women. It is indicated to reduce the incidence of breast cancer in women at high risk of breast cancer. Okay, so these are indications for hormonal treatment. So the dose of Mamofen, that is letrozole, for adjuvant and metastatic breast cancer is 20 to 40 milligram daily for 5 years. So there is now updated data of even letrozole is advised for 10 years follow-up data also available. Okay. Dosages greater than 20 milligram per day should be given in divided dosage, that is morning and evening. In ductal carcinoma in situ, the recommended dosage is 20 milligram daily for 5 years. Reduction in breast cancer incidence in high risk, recommended dosage is 20 milligram daily. So tamoxifen basically is a partial estrogen agonist effect. These partial agonist effects can be beneficial since they help to drive bone mineralization in the premenopausal woman. Sorry, there is a mistake in this slide. But also detrimental since they are associated with increased risk of endometrial cancers. Tamoxifen resistance is developed. The most common side effects associated with tamoxifen is bone pain, hot flashes, nausea, fatigue, mood swings, depression, headache, hair thinning, constipation, and skin dryness. Other side effects are like endometrial cancers. Endometrial cancers, you mean to say, related to the reproductive organs like uterus, ovarian, that way. Abnormal vaginal bleeding or discharge. So endometrial is basically the inner lining of uterus. Aromatase inhibitors. Coming to now aromatase inhibitors, they suppress the plasma estrogen level in the postmenopausal women by inhibiting or inactivating the enzyme aromatase, which is responsible for synthesis of estrogens. Unlike tamoxifen, aromatase inhibitors have no partial agonist activity. So coming to classification of aromatase inhibitors, basically traditionally amino glutamide is the first generation. Second generation aromatase inhibitor is formastine. And now the third generation are anastrozole, letrozole, and exemestane. Yeah, Fauziya, you are admitted. Letrozole is highly potent estrogen suppressor in postmenopausal women with early advanced breast cancer. For postmenopausal women, basically, so you can see in normal cells, the estrogen is released by fatty tissues, adrenal glands, apart from and in case of what is the role of letrozole? It inhibits this aromatase inhibitor. So the overproduction of estrogen ER from fat, muscle, and adrenal gland is inhibited. Okay. So in postmenopausal even you will ask from where the estrogen is released. So this is the answer for that. If fat, muscles, and adrenal glands also release, so aromatase inhibitors block that. As a result, overproduction of so letrozole and estrozole inhibits the aromatase enzyme. For before therapy, androgen found in both men and women is produced by the fat, muscle, and adrenal glands. Aromatase enzyme is needed basically to convert this androgen into estrogen from the various organs like fat, muscle, and adrenal glands and results in tumor growth. With therapy of letrozole or anastrozole, basically they inhibit the enzyme and block it from converting androgen to estrogen, thereby reducing the growth of tumor. Okay. So letrozole plays a role of blocking the aromatase enzyme and thus prevents the conversion of androgen to estrogen, which prevents the cell growth, proliferation, and breast cancer cell growth. So basically, letrozole, our brand name is Mamazol. Letrozole inhibits in aromatase inhibitors is a class of drug which helps in preventing growth of tumor by inhibiting aromatase inhibitor. So basically, it is a third generation aromatase inhibitor. So letrozole offers longer duration benefits than any other aromatase inhibitors. So as already I said, there is a data of up to 10 years. So letrozole is also advised. Duration is normally as per the response by the respective patient. Doctor suggests to continue or discontinue. Approved indication for postmenopausal events, early stage breast cancer, extended adjuvant, and advanced breast cancer. So which is recommended in first line and second line both treatment in case of ERPR positive in advanced breast cancer patients. So dosage recommended for Mamazol, that is letrozole, is 2.5 milligram once daily. No dose adjustment is required for patients with mild or moderate hepatic impairment. So adverse reactions include hot flushes, arthralgia, asthenia, edema, headache. So which are associated with hormonal treatment like bone pain, bone demineralization. So to manage this bone pain and bone demineralization, we will discuss further. There are certain treatments given as the treatment is going on for a longer duration. To manage the bone demineralization, there is vitamins, calcium, and even zoledronic acid advised. So coming to packaging, Mamazol, this is the packaging, letrozole. which is a strip of 10 tablets available in 2.5 milligram strength. Now coming to Womazol indications, the indications are same as that of postmenopausal breast cancer patient who are ERPR positive. So early breast cancer, locally advanced metastatic breast cancer, and advanced breast cancer. So all type of breast cancers who are ERPR positive, ERPR positive and postmenopausal. You have to remember this thing. So basically, hormonal treatment is advised in ERPR positive and postmenopausal. Adverse reactions are same, almost hot flashes, asthenia, pain, depression, osteoporosis, fractures, and back pain. So how to address this, we'll discuss. Insomnia, headache, edema, lymphedema. That is water retention in the breast cancer cells. So summarizing, tamoxifen, which has been gold standard in the breast cancer treatment in case of premenopausal women during adjuvant phase, has been compared with letrozole and anastrozole. So there are trials which are done. Aromatase inhibitors like letrozole should be recommended as a part of adjuvant treatment for postmenopausal women with hormone receptor positive. Letrozole has better cardiac safety as per the clinical data available as compared to anastrozole. So there are two trials, ATTACK and WIG. So where the comparison is done. So it is found that letrozole has better advantage versus anastrozole. But overall, it is oncologist which decides the treatment line. So toxicity and side effect management, which I was sharing with you, what if osteoporosis or bone mineral density is down? Then what do doctors advise? So they manage this toxicity by giving intravenous uh, zoledronic acid, which is given 4 milligram administered 15 minutes infusion every 3 to 4 weeks, was effective in preventing skeletal complications. So some doctors even start after 2 years of treatment of letrozole every 28 days. They advise to prevent further bone metastasis or breast cancer undergoing hormonal treatment because the duration is huge and letrozole has this anastrozole has this side effects. And even supplementary calcium with vitamin 3 is advised in case of bone density is reduced by the respective oncologist. Now, there are fewer combinations now available with evolving immunotherapy, targeted therapies coming in the market. So these are few combinations which are approved first line treatment, that is ribociclib plus letrozole resulted a significant longer progression-free survival than letrozole alone among the postmenopausal patients with hormone receptor positive. And then is another combination available now in ERPR positive patient, that is abemaciclib combined with endocrine therapies demonstrated again clinically meaningful improvement. So idea behind sharing this is that letrozole remains gold standard. There are newer endocrine treatment coming, and along with combination, it is extending further survival advantage. So packaging of Mamazol and anastrozole 1 milligram available. It is a strip of 10 tablets. Packaging of Mamofen, that is tamoxifen, 10 gram, and Mamofen 20, that is tamoxifen 20 milligram, which is available in a strip. Yeah, friends. Any questions? Mamasu, Fozia, any questions on hormonal treatment in breast cancer?
No, no.
So shall I take up another brand?
Yeah, yeah.
Yeah, what time you prefer a lunch break? What is the timing in your country now?
11,
11.
P.M.
So
11.
what time? So I'll continue with another brands then.
Yeah, you can go.
Okay. So there is one more brand which is we have finished. I think Madam has taken CML and Amatinib. No, already
Yeah, imagine
CML
Peterborough,
is done.
imagine.
Okay. So we'll take up now Capxcel, that is capecitabine.
Yeah,
Is
yeah.
there.
Is it the last one?
See, we have completed yesterday Riboria, Gabisoft, Temazole yesterday. So as per your agenda, is this is the last one?
Yeah. That's it.
Okay. Whether the slides are visible to you?
No, it's not visible.
Yeah, it's downloading. Everybody can put on their video. Hello?
Yeah.
Can everybody put on their videos? Webcam camera?
No, no. We
Hello?
are using. We are sharing screen.
Yeah, it is visible.
Yeah, it is visible.
So coming to Capxcel. So basically Capxcel is capecitabine, the first oral fluoropyrimidine carbamate. So before coming to details of Capxcel, it is recommended in colorectal cancer, that is CRC. C stands for colorectal cancer. So this is overall development of colorectal cancer treatment. So you will see that 5-FU is from 1950 to 1985 of you was the only drug which was available. Later on, there is addition of other drugs, series of other drugs. Even capecitabine came later. Okay, so these are all drugs which are used in metastatic colorectal treatment management. So capecitabine rationally designed to offer oral administration, continuous infusion of 5-FU. So it is a can say pro-drug of 5-FU, 5-fluorouracil, and it's an oral form. So there is an advantage over versus 5-FU, which requires administration timing. So convenient patient-oriented treatment. Patients are more comfortable with oral dosage form visa versus IV. So capecitabine is a tumor selective, provides targeted therapy, improves efficacy, reducing toxicity. So coming to the mode of action, it's a triple enzymatic cascade action. So basically in colorectal cancer, capecitabine gets converted in the liver to 5-DFCR, which is a chemical reaction which is taking place. And in the tumor, when it enters the tumor, the 5-DFCR gets converted to 5-DFUR, and which further gets converted to 5FU. So basically, capecitabine is a prodrug of 5FU. So the idea behind showing this is that capecitabine enters the GI tract, then in liver it gets converted to 5-DFUR, and when it enters the tumor cell, it gets converted. So the active form is 5FU in presence of thymidine phosphorus rylase enzyme. So is it clear? So due to the structure of Capxcel gets rapidly absorbed. So anything we have to convert to oral dosage form. So it is modified accordingly. First step of Capxcel is hydrolyzed by carboxylestrase enzyme. So here in this step, you can see the chemical reaction of Capxcel getting converted in presence of carboxylestrase in the liver to 5-DFCR. Okay, the same thing I have shown in a reaction form. Second step, cytidine deaminase, another enzyme which converts 5-DFCR to 5-DFUR. This happens where? In the tumor. And in the tumor cell, it gets converted to ultimately the active form, which is 5FU. So that's why it is called triple enzyme, because there are three enzymes involved in conversion from Capxcel to 5FU. So that's why triple enzyme cascade. So higher levels of 5FU are produced in tumor tissue than in the normal tissue. So why it is mentioned like that? Because when 5FU directly IV is administered, it may affect the normal cell. But here, since it get converted and reaches the site, so it's more targeted. And in presence of thymidine phosphorylase enzyme, it is expressed levels in the tumor tissue. So this enzyme converts the ultimately at the tumor site 5-DFUR to 5. So it's more targeted. So it Capxcel get converted to 5FU. Benefits of generating 5FU at the tumor site is results in higher tumor concentration, avoid systemic exposure. Avoid systemic exposure means, see, if when 5FU is given in IV form, it has its own side effects. So it may impact the when it is administered into the bloodstream and maybe another normal cells. So to prevent that, 5FU oral form is a better choice. Improves tolerability while maintaining high anti-tumor activity. Benefit of absorption of Capxcel as an intact molecule. Avoids release of 5FU directly into the gastrointestinal tract. Risk of gastrointestinal toxicities are reduced. So this is the mode of action. Ultimately, it impacts the DNA synthesis. So overall reaction impacts the DNA synthesis. And once DNA synthesis is impacted, the tumor growth, cell proliferation, and metastasis is prevented. So indications of capecitabine is colorectal cancer, and another indication is metastatic breast cancer. So adjuvant colon cancer, patients with Duke C colon cancer is another type of colon cancer. Metastatic colorectal cancer, first line as a monotherapy when treatment with 5FU alone is preferred. Metastatic breast cancer in combination with docetaxel after failure of prior to anthracycline containing treatment, as monotherapy in a patient's resistance to both paclitaxel and anthracycline. We already saw these protocols in breast cancer slides. Additional usage recommended are head and neck cancer and gastric cancer. So these are some other indications where capecitabine is used. So dosage of capecitabine, since its oral form, can be taken with water within 30 minutes after a meal. Monotherapy, the dosage is 1250 milligram per meter square twice daily orally for 2 weeks, followed by 1 week rest period and 3 weeks cycle is maintained. Such adjuvant treatment is recommended for total overall 6 months and 8 cycles total. So when you are calculating the dosage, you have to, as we know, multiply this 1250 with the body surface area. So you get the exact dosage and the tablet, number of tablets to be taken orally is decided daily. In combination with docetaxel, the recommended dosage of capecitabine is 1250 milligram per meter square twice daily for 2 weeks, followed by 7 days of rest period. Combined with docetaxel at 75 milligram per meter square as 1 hour IV infusion every 3 weeks. Every 3 weeks means 21 days. So reduce the dose of, in case of there is a toxicity, the capecitabine dose is reduced by 25%. In patients with moderate impairment, decision is taken by the oncologist depending on upon the uh, uh, renal impairment or clearance. Toxicities are hand-foot syndrome, nausea, vomiting. Contraindications are lactation, severe renal impairment. So side effects are predictable and manageable for that way. So oncologists know to manage the side effects. And they have trained nurses who manage the side effects with proper medications. So presentation wise, it's a 500 milligram tablet form available. Which is in the packing of 10 strips. In one strip, there is a 10 tablets. So this is the packaging of Capxcel. Storage condition wise, room temperature, away from sunlight and moisture. Keep out of children's any medicines. So overall silent features are oral. Capecitabine is an oral prodrug of fluorouracil, 5-fluorouracil, activated preferentially at the tumor site. So effective and convenient addition of intravenous polychemotherapy treatment of advanced breast cancer in pre-treated patients. So since it's an oral form, it can be given with other intravenous drugs which are there in the breast cancer protocol. Potentially as a component of first-line combination regime, effective and more convenient alternative to 5-fluorouracil as a first-line agent for treatment of metastatic colorectal cancer. Tolerability profile comparatively favorable, notable incidence of neutropenia and alopecia. Neutropenia is nothing but platelet count, which is managed by giving filgrastim or GCSF by the oncologist. Alopecia, hair loss, which generally come back after 3 months or once the treatment is completed. So oncologists normally counsel to the patients accordingly. More cost effective than comparator regimen because of reduced incidence of hospitalization due to the side effects. So it is more cost effective than IV treatment and more acceptable by the patients. So we will go through some breast cancer regimes, which already we had discussed in breast cancer slides. So capecitabine with docetaxel protocol. See, then with lapatinib in case of HER2 positive with Herceptin in combination with metastatic breast cancer with the capecitabine. and lapatinib again another targeted therapy. So idea behind telling that it is also combined with targeted therapies, and these are the protocols. In colorectal cancer, the regimes are these. So these are various protocols which are used in metastatic colorectal cancer. So there is a wide range of possible treatment sequence. So there are oxaliplatin based regimes, there are irinotecan based regime, and there are regimens with 5FU. So this is overall a glance given to you. So depending upon that, therapy after progression and before progression, the protocols are decided. These are various protocols which are generally preferred in colorectal cancer treatment, which also in combined with bevacizumab. So systemic therapy in advanced metastatic breast cancer. This is a clinical trial and making progression over 25 years. So it's showing the survival advantage in this protocol. So even in NCCN guidelines, you can see capecitabine is recommended in resectable metastatic adjuvant treatment in resectable metastatic diseases. So these are FOLFOX regime. So CAPOX, you can see C is for capecitabine. So CAPOX regime is capecitabine based regime. So just this is for only for your information. These are overall molecular pathways in colorectal cancer. So the cancer treatment is evolving. There is a combination of chemo, hormonal, and various targeted therapies coming. So which is happening because there are various hyperactivation of pathways happening in the cancer cell. As a result, scientists are identifying various genetic biomarkers, and depending upon that, the combination treatments are evolving. Okay, so we have completed the slides uh, and the presentation. Any questions, team? You have? Mamosu, Ozia, any questions on colorectal cancer or any of oncology related slides?
All clear.
All it's clear. Just wait a minute. I'll just check with madam. Would like to address a certain thing and I'll get back to you. Just hold on.
ये एक सेकंड है मेरे मीटिंग ये क्लोज करने में हेलो
Yes, madam.
हेलो ऑल ऑफ यू आर हियर
Yeah, we are.
Okay, so we are through with our training program. As per schedule, we have finished all the products and we have also done the basics of oncology for you all. I hope you all have understood everything properly, and please feel free to discuss anytime you have any doubts, any queries, you can contact me, and all the details are with Osama. He will make you all get in touch with me. Okay, and I'll be mailing you all the slides, and I'll also be mailing you all the recordings that we have done for all, the entire training program. Okay, so kindly go through the slides, prepare yourself well, and only then go and start promoting the products. And still, if you have any queries, please feel free to come back to us. Okay. So I wish all of you all the very best. Do well. Yeah. Anyone has got anything to say? Please feel free to speak.
Please.
Anyone? Yes.
Fauziya, Mamofen, yeah, want to share something or ask something?
Uh,
Mr. Ismail?
share the slides.
Yes,
Yeah.
Necessity.
definitely. Definitely we'll be sharing you the slides. Anyone? Anyone? Mr. Mamu, Ismail, Ifram. So then we can close the meeting.
Thank you, madam, for your
I didn't get
nice
you.
presentation.
We
Thank
can't
you.
hear you.
Hello,
Yeah.
can you hear me?
You need what?
Can you hear me?
Yeah,
Yes,
we
now
can
I
hear
can.
you.
Yeah, please. Thank you for your nice presentation.
Oh, that's fine. That's nice. Thank you. Thank you. Okay. Fine. So then we can close the meeting.
Yeah, you can.
Yeah. Okay.
Yeah.
So prepare well, do well. All the very best. Yeah.
Thank you,
Okay.
team.
Okay.
Thank you.
Good evening, Good evening,